It's my great honor and pleasure to introduce our next speaker, Professor O.Cohen from Israel. O.Cohen is a professor of medicine at the Institute of Endocrinology at the Haim Shiba Medical Center and Sackler School of Medicine, Tel Aviv University in Israel. He's active in promoting better care of diabetes with the use of technology through research and education of healthcare providers and patients. His interest in insulin pumps started in early 80s as his doctoral dissertation was based on stability of various insulin solutions for use in implantable insulin pump devices in 1984. He is also Director of Medical Affairs for Medtronic Diabetes Europe, Middle East, and Africa. Professor Cohen, welcome. The floor is yours.
Thank you so much, and good morning. And I'm apologizing to talking in English this morning. And it's been a pleasure to come to talk to you. And I want to thank the organization and Dr. Zvanis when I see him. And thank you, Dr. Milanis, Dr. Oxinos for chairing. My topic of today was insulin pumps. Now, it's a tough topic for, I would say, 20 minutes. So I would like to build up on Dr. Diangelos' lecture and discussing the change of the concept of insulin pumps from just a device that provides insulin to the people with type 1 diabetes into the concept that it is part of a solution, a therapeutic solution for those with type 1 diabetes. And actually today, it's the state of the art of therapy of type 1 diabetes. And I hope I will be able to provide you the data and the evidence to show that the change from the insulin, which was just from the insulin pumps of yesterday, that was just delivering insulin, to the smart, or I would call it the closed loop, the automated insulin delivery systems of today that now are proposing a different concept in therapy of type 1 diabetes. And this dramatic change has occurred in the last 2.5 years in Europe, and I will show you some of the evidence for the changes in the therapy. Now, why do we need automated insulin delivery system? I think this is a recent paper from a colleague of us, Dr. Kirsten Nogart, Professor Nogart from Steno in Denmark. She just looked, and it's a very good center, and she looked and audited the outcomes of the glycemic control of her patients according to the different modalities of therapy. And you can see very clearly the difference in the achievement in either insulin injections with sensors, some kind of a integrated insulin pump with only suspension of insulin when the glucose is going or trending to hypoglycemia, and the automated insulin delivery system. We see a huge jump in the ability to get better control. And this is a slide from the US, and it shows something very interesting. We all know that CGM that took over SMBGs in the way that we monitor glucose made a big difference for both patients and the HCPs. But what we need also to realize that although, and this is a study, this is the description of the total use in the US of pumps, CGM, and the result of those patients who reached the target of 53 millimoles or 7% A1C during the years 2008, 2018. So in 10 years, there was a revolution. The revolution was actually with CGM. From 2015 to 2018, just look at the blue bars, and you see this exponential increase of the use of CGM. The use of pump therapy didn't change much. But what was interesting, and this is very troubling, the percentage of patients reaching goals of therapy in type 1 diabetes increased a bit, but reached the ceiling. There is a ceiling effect if you're only using monitoring as the technology by which you use to treat people with diabetes. And to show you that CGM without automation and without algorithm is not enough, I just show you 4 of many, many studies who are showing 2 important things. CGM is good. CGM improves, but it's not enough. If you look at a FLASH UK trial just been published in the New England Journal of Medicine, they took people with type 1 diabetes, not well controlled, and they and they randomized them for using FLASH or not using FLASH. And at the end of the day, look, there was an improvement for 8.7 to 7.9, 0.6, 0.7, 0.8, even the reduction of A1C. But eventually, only 15% of those users achieved an A1C of less than 7. The Pilgrim, this is a cohort of HMO looking at all those who started using CGM. They saw very similar results. Nice improvement, not enough. In Sweden, they have a very good cohort of all people with diabetes in Sweden. And since the control of diabetes is quite good in Sweden, the effect of using CGM on SMBGs was really, really slow. So what's wrong? Why can't we reach better control with knowing the CGM? And I think this picture tells it all. This is a user, patient who came to our clinic, and we can say everything is fine with her. She's compliant. She wants to be better. She doesn't want to count carb. But at the end of the day, she's using CGM, and she comes with this kind of AGP presentation. Now, we see these patients every day. Why are we not successful in treating this patient? Or what do you do when a patient like this comes to your office? The first thing we do is blame the patient, right? Because we did everything. We gave him the best insulin, we got the CGM, you got everything. Why are you not controlling something? You're doing something bad. Second of all, we're blaming the disease. We call it brittle diabetes. If it's not the patient, it's not me, who's to blame? The disease. We call it brittle diabetes. But the real issue is that even if the way that we present the data here, why do we have the mean? Why do we have the median? The median is not what's really the life of this patient, because the real life of the patient lies between the lows and the highs. And if we treat the median, we don't treat the highs, and we don't treat the lows. We just find a compromise. And finding a compromise is the reason that we cannot get to better control. And the reason that we have to compromise in the system that is not using automation or algorithm is that we are basing the therapy of tomorrow on the patterns of yesterday, believing that the trip from Limassol to Larnaca tomorrow will be the same as yesterday. That doesn't work. That doesn't work. We need a different way of thinking how to treat the patients ad hoc, the moment it's happening, because every day is different. And here is why the automation and the thought behind algorithms is the way to move forward. Because when you design an algorithm to run the therapy, you don't use AI. You don't use witchcraft. You actually use mathematical equations to try to mimic physiology, solving equations that we know exactly what's following this. And this is done by using virtual patients, almost 10,000 virtual patients, that we do it again and again until we finalize the best algorithm that can be put in a device that can be put in a patient. So the first device that goes to a patient, it's not something new. It's something that already been tested virtually on thousands of patients in order to get it to the best results. Furthermore, the concept, and I think you've seen it from Dr. Dianglos' previous presentation, there's no assumption of the glucose from yesterday to tomorrow. There's no basal rate. There's nothing you provide for the future. You're only dividing according to the dynamics of the glucose the moment it happens. So if the glucose goes high, it calculates how high it is, how long the glucose is high, what is the rate of change. This is put into very more sophisticated equations and is provided every 5 minutes. Now, it's important that this calculation and this algorithm is fixed from a concept, but it is also adapted to the specific patient. That means if patient A has this level of glucose going down, he will get a different rate than someone else. And this is built on the last 2 weeks of data, which there is machine learning in the algorithm that adapts the specific coefficients of the algorithm to the patient. So this is the basal rate. You also discussed that if the basal rate is not enough, there's automatic corrections, but also automatic corrections is not waited until the blood glucose is high, and then there's a big insulin dose to fix the high glucose that happens. Actually, the moment the blood glucose is above 120, already there's a calculation going on. Does the patient need a correction bolus or not? And only then it's given, which is exactly what was mentioned before, trying to mimic the physiological beta cell. Now I want to go to another level that I think we don't always show this, another level of sophistication of the algorithm that not everybody is aware of this, and you don't need to remember this, and you don't have to teach this to your patients. It's just to know what's behind it, to give some credibility and some more trust into the algorithm, because at the end of the day, it's a black box that tells the patients what glucose, how much insulin they're going to get. And those are two modules which I like to talk about this, because I think it's cool. One is called the Safe Correction Bolus module. Now, I'll take a minute to explain this. When somebody is on MDI, injecting insulin, and the glucose is high, let's say before lunch, the glucose is 250, the patient wants to be 150, he has to reduce the glucose by 100, and by the calculation of sensitivity, the patient wants to give 2 or 3 units, and it just gives it in. And we wait to see what's going to happen. That's not what's happening with automated insulin delivery system. Because once the calculated correction bolus is done, it goes to a small simulator in the pump. Every pump has a simulator, which looks what's going to happen in the 2 hours in the future. And if in the 2 hours in the future, it is predicted that this correction bolus will cause hypoglycemia, it is cut automatically until it's predicted not to cause hypoglycemia. What do I mean? Every 5 minutes, every correction bolus goes for a simulator. This is something, I cannot do this with my mind, the patient cannot do it in his mind, but a chip can do it very quickly and very reliable, because it's going to do it the same way, in a good way, every time. So this is the Safe Correction Bolus. Now, if the correction comes after a meal was detected, the correction will be higher. So there's another level of sophistication, which if there's questions, I will be happy to answer this, but I just want to show you how much data is going into this simple correction bolus, and this is done every 5 minutes. But the more difficult part of treating people with type 1 diabetes is the meal bolus. How much to give to a meal? You know, we teach them how to count carbohydrates, which is a very difficult, and there's a lot of mistakes. We tell them to inject before meals. We tell them to calculate how much correction they need to do before the meals, how much active insulin they have from the previous. Very sophisticated, very complicated, and you know the patients, at the end of the day, find it very difficult to do. What does the algorithm do? The algorithm needs an input. It needs an input that the patient is going to eat. Now, the patient can just give a very accurate prediction of the amount of carbs, or can give just an estimate. What does the algorithm do? It takes this calculation of the amount of carbs, takes into account the level of glucose and the correction bolus that has to be given, and then goes to the same kind of exercise, which is a prediction, but now for 4 hours. That means they look 4 hours in the future, and if it is predicted to cause hypoglycemia, what does the algorithm do? it holds the hand of the patient. The patient will not be able to give the amount of insulin they thought if the algorithm sees that it's dangerous. We are not there to help them like this. Sometimes it's very frustrating for somebody who was treating themselves for many years and wants to get 10 units for this meal, and there's this black box tells them, no, you're not going to get 10, only 8. This is safe for you. We're taking care of you. It's not easy. It's a transition to all. But since this device needs to be effective but safe, this is how much effort and how much, I would even call it ingenuity, goes into the planning of each and every basal amount of insulin given, correction bolus given, and meal bolus given. So this is theory, very nice theory. How does it appear in the real world? Does it really work? You've already seen some of our previous works on the first 4,000 patients, but I'm happy to show you a new analytics of the last more than 100,000 patients. So this is not a story. This is not 5 people. That's not a case control of 100 people. This is 100,000 people, mostly in Europe, that are using this device. What can we learn? Number one, if you look at all the users, no biases, no looking at the best, not looking at the worst, looking at all the patients, 100,000, time in range 72.3%, below the 4% hypoglycemia that is allowed, and a GMI, which is an approximation of the A1C of 7%, that means that we already now reach the goals of the therapy in the majority of people. And what's interesting, and now I'm going to show you why this algorithm is so universal, because it works regardless of any biases, if you're young, old, rich, poor. Here is just to show you that the outcomes of those who are less than 15 years old and those who are older, who does better? The older. Okay? So older do better on technology than the younger. We can discuss why. But the fact is that that the results between the young and the old, which were always very, very different. We always said the younger was very difficult to control. The whole difference is getting smaller and smaller because it is driven by the algorithm and not the patient. But another important thing about using technology, use technology as intended, because you provide this device to users, both patients and doctors. Everybody wants to change it. It's like you're buying an automatic car. Why are you changing? You're not going to change the motor, right? To make it so you just use the car as intended, the way you bought it from the shop. The same is with the 780G or other pumps. You should use it according to the way it was intended. And if you do use it, look what you get. For those who are actually using the optimal settings, that is 100 target and an active insulin time of 2 hours. I don't have time much to go into this, but this is the way the settings should be done. Look at the numbers you can reach. 78.8% in all users. Older get 82% time in range. GMI 6.7. These numbers have never been shown before in people with type 1 diabetes. I would say end of the story at this point. This is the way to treat type 1 diabetes, if you can afford it. Percentage reaching the goal. Those users achieving the goals with the optimal settings get to 85%. Depends on the ages. So between 81 to 91% reach a GMI of less than 7. So all you doctors and nurses and educators, when you put somebody on a device which is automatically controlling the glucose control of the patient, you know what's going to happen. It's not going to be you're going to have to blame the disease, the patient is carb counting, not carb counting. You know what to expect. If you don't get this, you come to me. Yes, something is wrong. This is what you get, because 80% get to the time in range of more than 70%, a GMI less than 7%, and look, more than 85%, I think it's here, get the low hypoglycemia. So very effective, very safe. Now let's look at some, I have some more time, to show you how universal these outcomes are. First of all, again, it was seen before, do you have to be a perfect center, a huge center, a very rich country to get best results? The answer is no. If you look at this, and I call it the Eurovision of 780 results, every country has difference, but what's nice, almost all the countries reached the time in range of more than 70% and a GMI less than 7. So there are slight differences, but overall it works the same in the rich and the poor, and the strong and the weak, whatever you want to call it. Different countries, different results. And you can see Greece. I don't see Cyprus yet. The numbers have enough. We have to be at more than 100 to get this in. Anyway, so those are the numbers. You see different countries. I also did something very nasty, and I graded the countries, those with many patients, according to the time in ranges. And you can see, again, all of them are doing quite well, but there's some countries that are doing less than the others. And I asked, why is Poland better than Finland? And they're actually writing a paper on this as we speak. It's because they're just using the right settings. So people thought, maybe the different food, different style, different sports. At the end of the day, the more you're using the pump according to the settings that it was supposed to work here, and this is the users, where's the settings, active insulin of 2 hours. You can see in Finland, only 40% are using the right active insulin time, and in Poland, it's up to 65%. Let's go to other groups. And this is just, I made it especially for this meeting, and try to look at our recent papers that have not yet, but it's going to be published soon. So we looked at data from Latin America. And they showed that it doesn't really matter what previous therapy you had. In this case, did you come with just a pump with a suspend before low? Or did you come with the first level of automated insulin delivery 670? Or you just came from MDI? At the end of the day, if you just look at the second bar, and this for the MDI, they all get to the same number. It doesn't matter. You can start fresh. You can start somebody who never seen a pump before. You're going to get the same results. And here is something which is, people are asking, why are you showing this? Because those are not the greatest results. Only 62.5% time in range. And I really, really like this paper done in New Zealand by Ben Willer, because he came to me and said, listen, I want to do a study on my most difficult teenagers. They don't do anything. You won't be able to work with, they will not be able to work with the new automated insulin delivery system. And I said, okay, why not? Why don't you actually challenge them? Look at what's happening to those who are the worst. They don't do what you say. They teenagers. We know teenagers, right? And what happened was, actually, this is a great result from a 27.6% time in range and an A1C of 10 to get to 8 and 62.5. I think it's a huge result. So it's not the best, and when they grow up, they'll be better. But it shows you that we don't have to be biased against people who can do good with automated insulin delivery system. And this is the last one. If you cannot take picture of this, because I just received it a week ago from a friend of mine, Professor Gillard from Leuven in Belgium. They did a national, it's going to be published soon, they did a national audit of the 780, and they did fantastic sub-analysis of different groups. And I'm just showing you one subgroup of those who are obese or non-obese. Does the 780 work both on those who are lean and those who are obese? Maybe those who are obese have more insulin resistance and need a different algorithm. Maybe it's not working. So actually, what they did is looked at their cohort and looked at those who were with a BMI less than 30 and more than 30. Do you see any difference? The answer is no. Everybody gets to above the 70% time in range. And if you asked, was there a difference in the units per day, per kilo? Of course, there was some differences. But at the end of the day, the change in weight was minimum, and in all groups was the same. And usually, the increase in weight is due to the improvement in glycemia and less glucosuria. And I like it just to show you again how this same algorithm works in diverse population, getting to the to a good result. So I would like to end, and I'm happy I'm on time, for the changing paradigm of therapy, of technology with people with type 1 diabetes. In the past, we said, in order to get this therapy, you have to be the best. And if you follow the UK at the beginning said, in order to get a pump and a sensor and a closed loop, you have to go to carb counting school, do Daphne, do all kinds of educational in order. Only then, if you are excellent, you're going to get the technology. But what we are showing today is the opposite. Actually, almost everybody can benefit from the new technology. And only those who do not want to use technology, you cannot force them. But the concept is that not biasing and changing and choosing the best for the technology, actually those who are the worst are going to get the best benefit. And if you all know that NICE actually changed the verdict on this, and they turn it upside down, and that actually by law came just 6 weeks ago. They're going to plan that in 5 years, 60% of people with type 1 diabetes will be on automated insulin delivery system, which shows that even the most conservative HTA in the world, which is the NICE, also appreciates and understands the changing of the therapy of type 1 diabetes. And I thank you all for your attention, and if there's questions, please.
Thank you, Professor Cohen, for your excellent, most interesting data. Are there any questions from the floor? Whilst we wait for questions, perhaps, yes, please. Dr. Oxidas.
Thanks very much for your very nice talk. I just wanted to ask, how can we help the pump realize on a constantly changing insulin-resistant state during pregnancy? Because after 20 weeks, every week, the insulin resistance changes. And my question is, if we go and change the basal settings, go out of the smart card, change the basal settings, and do the 20% increase that we would have done anyway, and then go back to the smart card, will the pump take into account our change or not?
So very important questions about the use of 780 in pregnancy. Right now, it's still under warning and it's off-label. The point is, whatever you do for the basal rate on manual has no effect, has zero effect on the auto mode. So you can change the basal rates, it will not change the auto mode. Number one. Number two, it's true that insulin resistance changes in the different trimesters of pregnancy. And until I conducted a study, and it was done again in Leuven, on pregnancy, I did not approve to start using this in pregnancy. So in the paper that is now going to be, it was submitted to Lancet, you will see that using the 780 in pregnancy provides as good as results as the whatever is used in without 780, if it's MDI, if it's pump, whatever. Now this is really the use of 780 or automated insulin delivery system, and the two automated insulin delivery system provided the same outcomes. And the outcomes also with AID systems is not St. Vincent. It does not provide you less than 10% LGA, because it's still the targets and the physiology of pregnancy is different than in type 1, which is not pregnant, exactly what you said. Therefore, let's say in the clinic that I work and Dr. Milonas worked in when she was in Chiba in the pregnancy, we still try to use minimum 780 during pregnancy, because with a suspend on low, on open loop, you can go even to a more aggressive goals. But there are women that cannot get to these aggressive goals without a lot of work or because of hypoglycemia. Then they will do better on 780. So it's not a clear-cut answer that 780 will bring you to 10% LGA, no complications. What 780 does do for pregnancy, and this is critical, before pregnancy, it will provide the A1C that will minimize malformations. And if there's any important thing to say for the childbearing age is this: if you use automated insulin delivery system, you will not have, or you have the same as background of malformation, number one. Number two, during the pregnancy, to get the best results depends on the clinic's ability and the patient's ability. 780 will be as good as the other therapy, but if you have somebody who's struggling, definitely you can consider 780 as been shown just before. Long answer for a short question, but it's a bit complicated in pregnancy, as you know.
Thank you.
I have a question, if I may. Is there any data on use of AIDs in teenagers used early in the disease and beta cell function and metabolic complications further on? And also, in your data, you showed about 22,000 teenagers under 15. Do you have a subgroup of teenagers with eating disorders?
Right. So first of all, from real-world data, we are very limited because of the GDPR, because of the privacy. We don't have all these results. We only have glycemic and very general. So we don't get into these details. For this, we need specific clinic-based data. And here's the two main points. You asked, one is, do we have subgroups? So we don't have less than 15 because from privacy, you can only choose the ages of 0 to 15, 15 to 25. So there's no subgroup in that. But you asked something very important. If this is so good, why should we use MDI? Why shouldn't at diagnosis start automated insulin delivery system? And the answer is for two reasons: for health or the psychology of treating it more easy. Number two, should we preserve beta cell by having the best results from the beginning? A study that was done with the support of Medtronic called the CLEVER study, and it was published in JAMA about a year ago, showed very important things. Starting AID systems at onset will provide you the best outcome. The outcome of time in range was 87%. Versus regular therapy was around the 70% or 68%. Unfortunately, it did not preserve beta cell. Maybe because it was started a bit, not the first day, but beta cell was not improved. Verapamil, by the way, improved more the beta cell, but the AID did not preserve beta cell, but did provide much better control from day one. So what are we heading on this point? We are looking at studies that are going to start when the patient is in the hospital or in the clinic in the first day of type 1 diabetes. You take out the CGM, you take out the pump, you put him on, and send him home with this, and let's see the psychological aspects and how better controlled they are. So this is really where I think the concept is going to lead. Why should you treat somebody for 6 months or 10 months with MDI if he's going to be better on AID system? And there is always the saying, what happens if it breaks? Well, we still don't have donkeys in case the car breaks, right? So if you have something wrong with the pump, you just change it with another pump. You don't have to treat or teach somebody 2 years on MDI in case of breakage. But those are all new concepts, very hard to digest, and maybe the future will tell us where we're heading to. On anorexia, still no data, and we're waiting for studies on that if you're interested.
Thank you. Any other questions? Yes.
Thank you for an excellent talk. And you are very right that insulin pump should be for anyone that needs it, that wants it. We hope we can convince our governments for that. I have two short questions. One is in patients who are on 780 and they have, let's say, high blood sugar, 280, 300, and the autocorrection goes up to one point. So how do we overcome that? How the patient overcomes that? This is the first one. And the second one is, let's say somebody is going to have a meal and the blood sugar is 60 or 70. The 780, I don't think they let the patient put carbs in or they don't give them insulin. Is that correct? And how do they overcome that too?
So two short answers. One is, if somebody has of 780, 250, not because some mismatch, 1 hour after a meal, but let's say 3 hours after a meal, you know what he has to do? He has to change the infusion set because it's a set failure. Other than that, it should not go high that much. That's the main reason for that. Number two, because of the safe meal bolus we just discussed, if you start a meal very low or if you are trending down and the patient puts 100 grams and he wants, let's say, with a carb ratio of 1 to 10, is expecting 10 units, he's going to get 5 units, he might go high, okay? And this is on purpose because the algorithm says, let's sacrifice small hyperglycemia post-meal for less hypoglycemia 1 hour later. So what we say to the patients, okay, you're going to have some times like this. Look at the big picture. Look at your time in range. And sometimes you're going to have 250, not a big deal. It's not easy, but that's the truth. And by the way, we are doing some work on cost effectiveness. Actually, I wrote a cost effectiveness paper for Greece. So for governments that are looking at cost effectiveness, there's also a lot of data showing that it's good to start to treat people with type 1 diabetes from day one with technology.
We have time for one more question. Dr. Pavaitis.
Congratulations for this excellent speech. A minor problem that we have, that's continuously from the other question, is going with our patients with 780. Sometimes they have some fatty foods at night, for example, pizza, and they have very long hyperglycemia at night. And that, I think Dr. Piccolo's asked, is sometimes with these patients, the autocorrection works, but before, for example, with the 640, we are using the square wave bolus. Okay, now we have the autocorrection, but it delays to break it down, and it breaks it down in a delayed fashion. And these patients have good time in range, they have good HbA1cs, but we cannot avoid this hyperglycemic time. So the question is, okay, we can say, okay, we can find something to tell them. A comment about that, and if you think that newer pumps in the future that can solve these problems. Thank you.
This is a great question, and that's a great question because I have a great answer. So the question is, since 780 does not have a dual, doesn't have a delayed bolus, it's only have a fixed bolus before, how do they manage those very complex meals with high carbs and high fat and high proteins? Pizza is the greatest, not a pizza from Napoli, because they say their pizza is good and they got good flour, but let's say the pizza we eat outside Italy, so this is a study done in Chiba. They took people with type 1 diabetes, 2 minutes I have for this, is it okay?
That's fine.
2 minutes, not more than 2 minutes. So they took these people with type 1 diabetes, they gave them 9 times to eat the worst pizza in the world. The IRB approved it. They never ate pizza, and they tested 3 conditions. 1, open loop, the best open loop. Dual wave, more carbs, counting the fats, and the best of open loop. 780 with the correct carbs over 60, given in 1 shot, and even looking at what's happening if you just estimate the pizza is putting 40 and see what's happening. Now the result is the following. I'll just show you the results. The red is the best open loop. So everything is better than they're trying to guess what's going to happen 6 hours after this fatty meal. And that's what's the question. You eat a fatty meal, you never know what's going to happen in the middle of the night. Both the accurate 780 and the approximate 780 did much better with only 1 bolus. So the answer is the following. Remember, you might have a slight increase in the beginning, but at the next 8 hours, even 10 hours during the sleep, the outcomes will be better. So it's better to give 1 bolus. Now let's say you're really pushing the system. You're eating which is not good. Nutrition is good. This is a good opportunity to tell them, you know what, don't eat this. But let's say he really wants to, sometimes you split the bolus, okay? It's not fake carbs. It's actually, you give, let's say they're eating 80 grams. You give 60 now and 20 later on. In most cases, it's not needed. And it's going to be published and you'll be able to show it to your patient. So thank you for the question, and that's what I can bring you, that there's, by the automation, you get the second wave. It's not that you just give it once and nothing happens. If you give it once and there's not enough, then you get the autocorrections and the autobasal that will give you the second hump.
Thank you, Professor Cohen.
Thank you.
We'll close it there.